What's up, class? Back at it again with our lecture series. Yeah, I'm excited to be with you guys. We are again here with my handsome husband, Landon. He is our guest today. How you doing, Landon?
I'm doing good, thank you.
Good. You probably set it back up better. So today, we're going to be starting a new topic. Last time we learned about the lymphatic system and the immunity within the lymphatic system. But today we're moving on to respiratory anatomy. And then next class will be respiratory physiology. So today we'll learn about the pathway of airflow in our body. But quickly, let's review and do some Groundhog Day review from last lecture. All right, what are the 3 types of lymphocytes that we learned about last class?
B cells, T cells, natural killer cells.
Yes, B cell, T cell, and natural killer cells. That's perfect. What are the 2 types of T cells that we learned about?
So there's CD4, which goes
to the 2 types that we learned about in class.
The T cells.
Yeah, we learned about 2 types. One was kind of like a
helper T cells.
Helper T cells and
cytotoxic T cells. CD8.
Cytotoxic T cells. Landon's giving you the scientific name, the official name of them. So he's going above and beyond. Cytotoxic and helper T cells. What are our 2 main primary lymphatic organs that make these cells?
Thymus and the bone marrow.
Thymus and bone marrow. And thymus make what type of cell?
T cells.
Yeah, T cell. And then the bone marrow makes B cells. Exactly. Nice. What is the role of the lymph node?
They're kind of like the gas station stop for checking in on what's going on around the body.
Yeah, it's almost like a border stop. Yeah, I agree with that. They filter, they monitor the lymph pathogen, and if a pathogen is found, then they'll initiate that immune response because all the lymphocytes are in there. Exactly. What's the role of the spleen?
Kind of like the lymph node for the blood.
The lymph node for the blood. So it does the same thing the lymph node does for all that lymph, but it does it for the bloodstream. Nice. Boom. Okay. So, have you ever, I'm actually curious, have you ever seen in movies or TV shows where a Bic pen is used to perform an emergency tracheotomy? Like someone is choking or they're having an allergic reaction where their upper respiratory system is closed off. And so someone is like, oh, help them. And they take like this pen part out and the butt cap and they like stab the person like right here to like help them have an airway. Have you seen that, Landon?
It's like the Born Identity. There's one.
Oh, is there one in there?
Yeah, there's something with a big pen in there.
Oh, that's pretty cool. Okay, and then I actually saw this on a TV show called The Blacklist. So they do this on The Blacklist for somebody, I'm pretty sure. So it's pretty intense. But this connects to today's topic. Also, what's another time you've seen like a tracheotomy type of thing used? Have you guys know any other circumstances where those are used?
Is it like people who like just try to enjoy a smoke and then like
smokers? Like, have you guys seen those ads where they're like, don't smoke? Like, and they have those like things where they use like a special mechanical thing they hold up. And it's like, I used to smoke. You know what I'm talking about? All these things have to do with the anatomy of our respiratory pathway. So we're going to be talking about that today. So the first part of your respiratory pathway is your nasal cavity. So this is the area between our nostril going all the way to the back of our throat. So you guys have this this note printed out for you so you guys can label it as we go, because I'll point directly to what you guys have. You have this on a piece of paper. And the nasal cavity has something called nasal concha in it. So the word concha, it's coming from that word similar to conch shell. And these are 3 ridge-like bone protrusions coming into the nasal cavity. And then they'll be covered with like that soft tissue. But they're actually a part of the skull itself. So I have a question for you. What is the purpose, do you think, of the nasal concha that's in your nasal cavity? So for some reason, that nasal cavity isn't just open, like an open, complete airway. There's these things in the way. Why do you think these things would be helpful or useful? What do you think, Shannon?
I actually don't remember. I think it's for increased surface area to humidify the air.
Yes, it does have to do with humidifying the air. What else? Like, what other things could you
It's
kind
like
of think?
filtering.
Yeah, filtering, totally. Yeah, so good thinking. These nasal concha, essentially they're gonna swirl the air. So as the air comes in, they're gonna hit the concha, so it'll kind of make a swirl of the air coming in. And that slows down the air, and that's important. Firstly, because it will slow it and warm it. So that's really important because our lung tissue is really sensitive. So we don't want like freezing cold air coming into like our alveoli or something because we could damage it. So we want to warm the air. But also it will trap pathogens. So like you said, Landon, you want to filter the air. So we breathe like chemicals and different pathogens and stuff in, and we don't want all that going into our lungs. So this concha is like the first line of defense to stop that. As it hit the walls, it can get stuck on the walls, and then we can like sneeze it out, or can get caught up in our snot. We can blow it out into a tissue, right? And then it also will help with our sense of smell. So because the air is stalled or delayed in that cavity, it allows our olfactory bulb, which we're about to learn about, to have the time to actually pick up those like smell chemicals basically and read them so we can get a better sense of smell. So yeah, good stuff. So yeah, the next structure is our olfactory bulb and our olfactory nerve, which is our cranial nerve 1. The olfactory bulb takes an odor molecule from the air. So we breathe in air, and in the air there's tons of molecules. And so there's different things that we can smell, and that odor molecule will come in contact with the olfactory bulb, which has 400 different types of receptors. So they're all trying to sense for different types of odors or odor molecules. And so like, what's like a strong odor like that you remember maybe from your childhood? It could be positive or negative, Landon.
Pumpkin bread.
Oh, pumpkin bread. Did your mom make pumpkin bread?
Yeah, it's good.
Oh, that's that's like a pleasant memory.
Yeah, it's a good smell.
I think my favorite smell is like gummy bears melting. Yeah, pretty good. I remember my Oma, like my nanny who used to watch me, she would always have gummy bears in her purse, and then we lived in California, so it was hot, and they would melt, and I would smell them in our car. And so I was like, oh, this is so nice. But essentially, those molecules of odor are interacting with these 400 different receptors. And it's not that just one smell reacts with one receptor. No, say in the case of your pumpkin bread example, the pumpkin bread could hit, maybe light up 50 of these different receptors, or 28 of them. And then those receptors that are buzzing off like, hey, there's this type of odor, will be organized and coded and then sent to the olfactory nerve for the brain to then like take in and process. So I have a question for you. With the 400 different receptors, and a variety of them can be turning on and off, how many different smells do you think humans can detect?
Actually not a ton. I think it's like a few thousand.
It's actually more because I'll let you do another guess, because the receptors, like say if you have receptor 1 and receptor 28 on, that's one smell.
All the permutations, but
yes.
Like the actual being able to differentiate.
Oh, okay, yeah. Okay, but I'm talking about the permutations. How many smells?
The permutations, oh my gosh. I don't know, like millions.
Over 1 trillion different permutations of smells that a human can detect. And in some people, it's even more than that, which is crazy. But going past the smelling, because we'll go through the senses in another lecture, the next structure we want to talk about is the sinus cavities. So the sinus cavities are these right here. And what the sinus cavities do is they're mucosal membranes. So they're making mucus. And what they do is they add moisture and warmth to the air, as well as trapping debris. So if you check this out, these are the different sinus cavities that we have. I don't need you to know the names of all of them. But interestingly enough, these sinus cavities are also cavities within our skull. So in addition to adding warmth and moisture to the air we breathe, It also makes our skull lighter, which is kind of cool because those cavities are wide open. But on top of that, what was I going to say? Oh, that might have been it. Let me see. Oh, wait. Oh, I think I wanted to say, like, when we get sick, like, our sinuses get, like, they hurt. Like, here and here, you know, when you get sick, those hurt. That's because we're producing excess mucus, and that builds up the pressure in those cavities. And so it can be really painful. I actually have a little cold right now, so I can feel that going on. But essentially, this is like the snot that we're talking about. Like your snot, they're made in the sinus cavities, right? In those mucosal membranes. Okay, what 5 tastes can we detect? Because right now we're talking about the oral cavity, which is this giant cavity right here, beneath and separate from our nasal cavity. And we're talking about our tongue, which takes up a majority of our oral cavity. I think a lot of us don't think about that. We think our tongue kind of takes up a small portion, but that's not true. It's a majority of our oral cavities being filled up by our tongue, which is kind of funny. So what are the 5 tastes that we can detect?
Sour.
Sour is correct.
Sweet.
Sweet.
Bitter.
Bitter is correct.
Umami.
Umami is correct, which is like savory.
Is it unami?
It's umami.
It's umami.
Yeah, I mean, I'm pretty sure.
Are you
I
sure?
may be wrong. I think it's umami.
Where's bitter? It's probably not.
Like pretzels.
Salty.
Salty is correct. Got all 5. Sweet, sour, bitter, salty, and umami. Maybe unami. You can check that for me. Landon's gonna look it up. But that's our savory sense. We're gonna talk more about this in our senses section. But after our oral cavity up here, more toward our nasal cavity, at the end of it, we have this little opening, and this is called the eustachian tube. The eustachian tube. And the role of the eustachian tube is to connect your nasal cavity to your middle ear. So when we think about our ear, a lot of times when we're thinking about like the canal of our ear, we're just thinking of the outer ear, which is from the outside of our ear that we can touch and see. And then if we shove like a Q-tip in there, which I guess you're not supposed to do, but if we did, we would eventually hit the eardrum. All of that space is actually called the outer ear, even though we feel like that space is a part of our inner ear. It's not. All that's the outer ear. Then the space in between our outer ear and then what's called our inner ear, which will actually detect all the auditory sounds and take in those waves, is what we call the middle ear. And this is the space that actually connects by the eustachian tube to our nasal cavity. And this is actually the reason why young kids get a lot more ear infections than adults do. And we'll explain that. But real quickly, this is also why when you're on an airplane, sometimes your ears like pop, right? That's because the pressure in your nasal cavity or outside of your body is different than the pressure within your middle ear. So people tell you to chew gum on an airplane because that movement of your jaw and facial muscles will actually kind of open and close this tube so that that pressure can regulate and be equal, like reach equilibrium. And that's when you kind of pop your ears. That's what you're feeling, is the eustachian tube equalizing the pressure between your nasal cavity, which is like the outside air pressure, and your middle ear. But real quickly, this is super interesting. Why do little kids get ear infections so often? This is because when you're young, your eustachian tube is more narrow, but even more importantly, it's more horizontal to your ear and your nasal cavity. As you age, that angle gets greater or less. So it's like right here, it's 180. Now it's like, what would you call that? 45 degrees. So when it's horizontal, pathogens like bacteria have a lot easier job traveling between the nasal cavity and into the middle ear. And because it's more narrow, there's a lot more blockage that can happen. But as you age, those different bacteria can just almost like drain easier, go out easier into the nasal cavity so that you don't get as many ear infections. kind of interesting. Do you have anything you want to add to that, Landon?
Yeah, one of the things too with infants is just that they get so much mucus built up
Yeah.
that they're not really blowing their nose themselves.
Oh, that's a good point.
So if you just clear the mucus enough, then like it'll help prevent that actually.
Huh, so that's good for our babies. Like if we like use saline to drain that, then they have less chance of like actually.
And the most common bacterial infection of a middle ear, so you have the otitis media, which is like a middle ear infection.
Yeah.
Streptococcus pneumoniae.
Okay.
And then you have H flu, and then Moraxella catarrhus.
Okay, let's go. Thanks, baby.
And you would treat that with amoxicillin.
Let's go. Now we know.
Now you know.
Okay, so moving down, we just were at the eustachian tube here, but moving down to the back of the throat we call the pharynx. And it's just like literally a fancy word for that. But you see that the nasal cavity and the oral cavity are separated by this part of skin. That's like our palate, like the top of our mouth. And then the very back of that separation is called the uvula, which we all know is like when you open up, you go, that middle thing that dangles is the uvula. And then to the left and right side of that, that would be the tonsils, right? I thought this was a really interesting picture because someone got their uvula pierced, which sounds like crazy to me. Like, that sounds incredibly painful. What's like the craziest piercing that you've seen, darling, recently?
That's some of the tongue piercing, I guess, isn't
tongue all the way through?
Yeah, all the way through.
Oof.
So it didn't hurt, though.
I think they're lying.
You seem like a trustworthy person.
Okay. Well, I bring up this really disgusting gif of a little boy who's able to put a noodle through his nose into his mouth and like bring it in and out because, as you can tell, there is at the very back of our throat, there is a place where the nasal cavity and the oral cavity almost meet. That's why he's able to do this with the spaghetti. All right. Next, as we're traveling down, we have these different features. We have the esophagus, which we already know about. That's the tube that goes into our digestive tract. Then we have the trachea as we go down, and this little flap of cartilage that's called the epiglottis. So the epiglottis is a piece of cartilage that blocks the trachea when we go to swallow. So if we were to swallow and we didn't have the epiglottis, the food or water could equally go into the esophagus and down our trachea, which would be really problematic because that means we'd just be dumping food and water into our lungs. But we don't want to do that, right? We want to block the passageway to our lungs to protect them and make the food go into our digestive system. That's why we have the epiglottis. But funny enough, I was thinking about this guy. Firstly, I want everyone to know this is like the universal signal of choking, and I feel like people don't use this as much, but like if you are choking, make sure to do this signal so someone can help you. You cross your hands, put it by your throat, and be like, and they'll know. They can give you the Heimlich. But funny enough, when you're eating, this is what happens. Like, say if you're eating and then your friend tells you like a funny joke and you start to laugh. The laughing itself will interrupt the very synchronized process of swallowing, and that epiglottis will sometimes flap up, and that's how you can choke when you are like laughing when you're eating, or if you're talking when you're eating. Sometimes you can choke because it messes up the movement of that epiglottis. So that's what's happening there. All right, now as we're entering the trachea, at the very top of it we have something called the larynx. And the larynx is this opening that's going into the trachea, but in the larynx are the vocal cords. And when air passes through the vocal cords, they vibrate. This is a gif of that, which makes sound. So what do you think's happening right here with this person as this is happening? What do you think's going on with them?
They talking or singing?
Yeah, they're singing. They're singing. So you can see the vocal cords, as they stretch and change shape, that'll actually change the pitch and the tone of their voice. And men have longer, more robust vocal cords, which have created deeper voice, deeper sound than women. And so Yeah, I think that's all we did. And it also regulates airflow, so this is another big deal. The larynx and the vocal cords work together to actually allow us to cough. So it's a pressure buildup. So when we're about to go to cough, we'll close the vocal cords and allow like pressure to build up behind them. And then when we release it, this big burst of air comes out. You know, you can feel the pressure of a cough. And that helps you expel something. So the larynx is actually what regulates the airflow and allows you to do different things like coughing. I think that's it. Oh yeah, and then a typical thing with the larynx is like laryngitis. Like we've all heard of that, the inflammation of the larynx. Would you want to add anything with laryngitis?
You'll have something called an inspiratory stridor.
Oh wait, I can't hear that good.
Oh, so like when you're looking at someone, you can like hear them. They'll like when they breathe in, they'll have this really high pitched sound. It's called an inspiratory. You have inspiratory and you breathe in, expiratory and you breathe out. Stridor is the sound of it. And so laryngitis, also when you do an X-ray, you'll see something called a steeple sign, which is just kind of like that part of the trach getting like really thin. And I think the most common cause of that is paramyxovirus.
There you go. Thank you. All right. So right in front of where the larynx is, anterior to it, is a piece of thyroid cartilage. They only call it thyroid cartilage. It doesn't have any thyroid function, but the thyroid surrounds it or is next to it, and so that's why they call it that. But the thyroid cartilage we all call the Adam's apple, so everyone can feel your Adam's apple. Both men and women have this thyroid cartilage, and what that's doing is just protecting the larynx, protecting those vocal cords from getting injured or damaged. Now in men, the thyroid cartilage is bigger, and this is because during puberty, testosterone will act on the larynx to change like the vocal cord structure, make them deeper. This actually causes greater increase of the thyroid cartilage to grow. So that's why their Adam's apples are like generally bigger, more pronounced than in women. Okay, now as we head down, we said the trachea is the windpipe. Something interesting about them is that there's actually cartilage rings that are surrounding the trachea. And what those cartilage rings are doing is they're permanently holding the trachea open. Because say if we're like laying down, we're asleep, we don't want it to fall flat like the esophagus could. Because this is our airway, then we wouldn't be able to get air or anything. So the trachea has these rings of cartilage to ensure that it's being held open 24/7, no matter what. Oh, and interestingly, the cartilage rings are just on the front side of the trachea, because the back side, this picture is kind of like wrong. There's not like a separation between the esophagus and the trachea. This wall is a shared wall. So the back side of the trachea is smooth muscle, because this is also the beginning of the esophagus. Like they share this same wall. So the back part of the trachea doesn't have cartilage on it because it's the same wall that's being shared with the esophagus. Okay. Moving down, we have the bronchi and the bronchioles. So the trachea will branch into two separate airways to go to the left and the right lung. And the bronchi itself will then divide even further into bronchioles, so that we evenly distribute air throughout both of the lungs. So we see the eoles ending in other things we've learned about. What other things go from like something to eoles of that thing?
Like arteries and arterioles.
Arteries and arterioles, that's a great example. So blood vessels, the arteries. Then as they get smaller, they turn into arterioles. What's another one?
Oh.
In the blood system also.
Like the veins.
Veins, yeah. And
like the capillaries.
Venules.
Yeah, the venules.
It's like the same thing. So as the bronchi get smaller, they turn into bronchioles. And a lot of people call this the bronchial tree, because you can see as the trachea then breaks and then continues to break into the bronchioles. If we flip that thing 180 degrees, It looks a lot like a tree, doesn't it? This kind of looks like a Dr. Seuss tree. So they call it the bronchial tree. Okay, so as we go, oh wait, did I not? Okay, I'm gonna go here next. So the bronchioles lead into something that we call the alveoli. This is like the most important part of the lung, the most important part, because these are our balloon-like sacs where gas exchange actually occurs. So when we breathe in, the main thing we're trying to accomplish is, hey, we want to exchange carbon dioxide and oxygen. We're breathing in what? Oxygen, and we breathe out carbon dioxide. CO2. So where that thing is actually being exchanged within the blood system is through the alveoli. So it's the most important. And this is all happening in the lungs. So we have a left lung and a right lung. I kind of gave this away, but maybe you weren't paying attention. But the left lung has 2 lobes and the right lung has 3 lobes. So it's kind of interesting. Why don't both lungs have the same number of lobes? What do you think, Landon?
Well, the right side doesn't have to make room for the heart.
Exactly. The right side doesn't have to make room for the heart. The apex of the heart, the bottom of it, is pointed to the left. So although the heart's pretty central in our body, it's shifted to the left side. So that left lung needs to be a little bit smaller. So it only has 2 lobes. And then the right-sided lung has 3. So your lungs aren't the exact same size as each other. Then we talked about the alveoli. What is this thing on the bottom here? What is this muscle called?
The diaphragm.
The diaphragm, exactly, the diaphragm. And the diaphragm, when it contracts, as we know, it contracts downwards. That's kind of interesting. It's kind of counterintuitive. When the diaphragm is relaxed, it's a dome shape up like this. But in order to breathe, we need to contract the diaphragm. So everyone inhale right now. You can feel your diaphragm being pulled downward into your body, which allows you to inhale. And we're going to talk about how the mechanism of that next class. But in order to exhale, you just have to relax your diaphragm. And that causes expiration. So, exhalation, expiration, exhalation. So when you inhale, you can tell it takes more effort than when you exhale. Try that. Like an exhale kind of feels like a release. That's because exhale is passive. You're just allowing your diaphragm to relax, where inhaling actually takes an active contraction of that muscle. All right, and here's the respiratory pathway that we learned about. Start in the oral and nasal cavity. Go to the pharynx, which is just the back of the throat. Then down the larynx, where our vocal cords are, the trachea, the left and right bronchi break into bronchioles all throughout the lungs. The left lung has 2 lobes, right lung has 3. Then it gets to the alveolar sacs. That's the actual place where that oxygen carbon dioxide is exchanged, which we'll talk more about next class. So Landon's going to come up to the front of the class and give you a patient presentation and present a problem to you. So get out a piece of paper. You'll spend about 5 to 7 minutes. You can go onto your Chromebooks and research what you need to answer his question. You'll turn it in to our professor that's in the class, and then Landon will give you the answer. Thanks, guys.
Good morning, class. You guys just listened to a lecture on the respiratory system and the anatomy. There's a lot I could do with that. There's a lot of stuff that happens with the respiratory system because it's really closely tied to the immune system and actually the cardiovascular system. So I'm going to give you a patient that kind of connects the 2 of those. So you have a, say, 58-year-old female who's postmenopausal, who flies from Singapore to London, and however many flights that takes, however long the flight is. But she takes a long flight, she gets calf pain. She kind of ignores it for like a couple days, and then all of a sudden she gets this really sharp chest pain. Presents to the emergency department. You see her. She has difficulty breathing. she's using accessory muscles to breathe. So your primary muscle to breathe is the diaphragm that Ms. Cose talked about that pulls it. But even when you're doing a lot of exercise or if you're in respiratory distress, you have your intercostal muscles and some of your abdominal muscles, which your body will recruit to help breathe if it's having difficulty breathing. So when you're examining someone, if they're using something to tell if they're in respiratory distress or having issues with breathing, is if they're using their secondary or accessory muscles to breathe. So she's using her accessory muscles to breathe. Her O2 stat is 88. Blood pressure, say it's like 105 over 70. She has this chest pain. You hear about her history, her long flight. She has calf pain. You get a CT scan of her chest. And question 1 is, what are you expecting to find? And question 2 is, why did it happen? What caused it? And for fun, question 3 is, how would you treat that? And I'll give you a few seconds to think about that. Or a few minutes to think about that, look it up. Okay, so this is a classic presentation for a pulmonary embolism. So you have
And they actually looked that up before because remember I had them when we went in and we were thinking I had a pulmonary embolism. Do you remember that?
Oh, yeah.
So I gave them my patient presentation. So they might be able to get this one actually, which is kind of a win.
Well, cool. So that's great because I want them to think then about the cardiovascular part of this. So yeah, you're thinking of someone who, one of the most common places to get like a blood clot is in like kind of the popliteal fossa.
What is that?
So that's behind your knee, and so this is a venous embolism, right? This is a blood clot. That's because your veins have valves, the blood's slow, so if it stops, it coagulates. And so like even when you get blood, when you cut your finger or something, you see the blood clot pretty quickly. Your blood's gonna do that if it's ever stopping at all. So with something like atrial fibrillation, which is the atria not contracting kind of in rhythm, there's something called the atrial appendage, which is like a little like pocket in the left atrium where like blood can slow down if it's not pumping correctly. But in the knee, popliteal fossa, it's a really common one. Long flights, you're sitting, you're in coach, you're like all scrunched up. So then that will go through the venous system now. That's an emboli, which is a blood clot that's moving. Where's it going to go next, right? It's going to go venous system, right atrium, right ventricle. So from the right ventricle, it's going to the pulmonary arteries. Now, if the blood clot is really big and gets in the pulmonary arteries and it blocks it, you're just dead. But if it's maybe a little smaller, it'll go through the smaller pulmonary arteries and then clog and then block like maybe a different type of lobe. So one thing you can do to check that is something called a VQ test, ventilation perfusion, VQ. So what happens is your lungs have essentially 3 zones of blood perfusion and air availability. So the top part of your lungs have the most oxygen but the least amount of blood. Zone 2 kind of has a mix of the two. Bottom lungs have the most blood flow but the least amount of oxygen content. So that's why when people are getting severe COVID, they lay them on their stomachs so you can get more blood flow to the top part of the lungs, which had the most oxygen. But anyway, so VQ mismatch is essentially saying, hey, they have really high ventilation but no perfusion. So that'd tell you that there's a blood clot. So I answered all the questions I told them I was going to talk about.
Yeah, how do you treat it?
Oh, treat it. Thanks.
Yeah.
So what you want to do, depending on it, like if it's really big, it'd be surgical. But if it's kind of a smaller one, you would just give a blood thinner. And so blood thinners are just going to essentially like just keep your blood from clotting, and then that'll kind of work itself out, and then just kind of monitor them. But there's the patient presentation for the day.
Yeehaw!